Good morning, everyone. I'm very happy to be here amongst this August gathering, and I congratulate Dr. Hari Kishan and Dr. Preeti here, the organizers, and thank you for calling me here to talk about this important topic, which is very close to my heart. So I'm going to dwell on the last line, which Arjun just spoke about. He said before going on to these gadgets, these fancy gadgets, and talking about big things, doing TBNAs, the core biopsies, the basic thing in lung cancer is smoking cessation. Now, it is a preventive measure which is going to make a large population, a large chunk of your population getting prevented from the disease in itself, by itself. So I am going to be here talking about the integration of smoking cessation with lung cancer. We don't need to wait for a lung cancer program to set in and then start thinking about the most basic of the preventive measures, which is smoking cessation. Should smoking cessation be a part of lung cancer screening in India? Now, in context to India, that is a very difficult question because as we have all heard it, there is paucity of data from this part of the world regarding the amount of smokers which we have. Though we have a large amount of studies which are available to tell you that the percentage of population which uses tobacco in any form in India is about 28.6%, as compared to US population where only 20.8% of the population is using tobacco. And then on the other hand, in US, we have seen about 85 to 90% of the smoking population is getting lung cancer. So a large chunk of their population is smoking and they are able to find the lung cancers in this population. As against the heterogeneity which is present here in India, 30 to 70% of the males were found to be having lung cancer in the smoking population. On the other hand, the data was still lower in female population, only 12 to 46%. What do you do about the rest of the population, as Dr. Sushmita rightly pointed out? Now, another thing, if you look at the lung health programs, which Dr. Ashutosh just focused on, we don't need to focus only on lung cancer in terms of what smoking can cause to your lungs. We all know that TB is also related to smoking population. We get a large chunk of population wherein a patient comes to you, says he's a smoker, then that is a risk factor for not only tuberculosis, but COPD as well. So that is where the emphasis lies. Not only lung cancer, but overall lung health is important. Now, as compared to Indian data, the differentials on a solitary pulmonary nodule in US is not a major problem. As we spoke about it, 22% of false positivity in India, and many of these are having tuberculosis. Still, I would say we need to biopsy these lesions because we need to know the accurate diagnosis since we are into precision medicine. Doctors offer quit advice to less than 50% of smokers coming to their clinics, and we all know this. We have busy clinics. We do not talk about smoking cessation to all of our patients. As compared to 91% of smokers who are offered advice to quit in these specifically designed programs in the US. More than 80% of tobacco-related deaths are projected to be happening in the low and middle-income countries by about 2030, and this is not true for the US population. Are we going to leave the additional 18% mortality reduction by combining the programs of smoking cessation with lung cancer screening? What I mean is that what Dr. Kumar Prabhash already told you, 20% reduction in mortality when we get in the lung cancer screening program, and 38% reduction when you are combining your smoking cessation along with your lung cancer screening. However, long-term follow-up would be a major problem here in India, which was just spoken about. And long-term follow-up in the USA is not a problem since additional costs may not be an issue there. The biggest problem is relapse at about 1 year, which is very, very high here in India. So you have to follow your the smoking population for about a year to be sure that they have actually left smoking. And since we have better structured programs in USA, this thing is better as compared to India. We all know that smoking is the largest single preventable cause of disease and premature death. And we cannot tell our population that, yes, look, since we do not have the means and measures, we are not going to screen you. Smoking cessation, most effective preventive method in stopping its deterioration, even in current smokers, if they have got lung cancer, it prevents upstaging, and stopping at any age is helpful. The moral hazard arising out of a negative screen. If you're doing a CT and the CT scan is negative for any lesion, your patient is getting the indication, a clean slate, that yes, you can continue smoking, but this should not happen. Hence, smoking cessation should be an integral part of lung cancer screening health, and it should motivate your patient to quit. It could not act as a teachable moment in your patient population if you're not integrating lung cancer with smoking cessation. In US, we see about 40% of the candidates are actually heavy smokers, which may not be true here in India. And integrating the services are going to increase the access and reduce disparity amongst our population. So this was already spoken about. I'm going to just move forward. Adding smoking cessation to intervention to lung cancer screening obviously will result in cost effectiveness. Whatever structure we have in terms of lung cancer screening clinics, we can integrate into smoking cessation clinics and then see what is happening to the population. The economic costs attributed to tobacco from all diseases in India in about 2017 to 2018 for persons more than 35 years was about 1.77 crores, which is a huge amount. If we get this menace down, we are going to divert our funds for better causes. So what is the magnitude of smoking problem here in India, and what states are affected? This is the prevalence of current tobacco use, the GATS study, which was done in 2010 and 2017. This is comparative graph between the two. You can see that tobacco users has actually gone down in the GATS-2 survey, which was done in 2016 and 2017. Also, we had less number of smokers as compared to 2010 data, which was 10.7%. And smokeless tobacco, I would say that it has actually gone up 21% as against 25%. So GATS-1 to GATS-2, the prevalence of tobacco use has reduced by 6 percentage points, and the number of tobacco users has reduced by about 81 lakhs. Again, I would like to show this slide that we can see that the states which are most affected are present in the northeast region of our country. And I'm happy to share then the first session of today was here about AI and how you can integrate these systems to detect lung cancer early, about the lung nodules. This AI is coming up in Northeast, and I'm happy that there is already a system in place and a study in place in the state of Assam. Because you can see here that Mizoram was the most affected state in terms of use and prevalence of current tobacco smoking. Amongst all the states in India, it was 34.4%. And the highest age-adjusted incidence rate and mortality was found highest amongst the males and females in Aizawl district of Mizoram, which is against the Northeast. If we compare the data amongst the adolescents and the younger age group, we see, again, the northeastern states are a problem. The prevalence of smoking is very high. It is about 58%. Then we need to focus our smoking cessation clinics in this part of the country. So what is the current infrastructure, if we can talk about it? regarding the tobacco cessation clinics. Dr. Arjun just told you that there are systems in place about the tobacco cessation clinics, but how much of us are actually using it? On paper, we actually have about 429 tobacco cessation clinics, which is a big surprise to all of us here. It was started in 2002, starting with only 13 clinics by the Ministry of Health and Family Welfare, which was increased to about 19 in 2005. But currently, we have 429 centers. And this excludes the unmapped centers which are coming up in the private sector. Now, another problem in India is about the heterogeneity of the population as well as the heterogeneity of the healthcare which is present here. We have two types of healthcare here. One goes along the public forum and one which is on the side of private institutes. So this is what we were talking yesterday, wherein I liked a statement by Dr. KP who said that on one hand we have a bullock cart here in India, and on the other hand we have a Mercedes running on the roads. So a lot of heterogeneity in terms of how healthcare is delivered here in India. NIMHANS in Bangalore is the nodal center of all these tobacco cessation clinics, and we have discrepancy between the lung cancer screening programs in present and future, which is going to arise. How to integrate them together is going to be a big issue. How to integrate these services with lung cancer screening? We have paucity of data in terms of lung cancer screening, which was already spoken by Dr. Arjun. Now, when to do it? When do you intend to do the screening of population for smoking, for asking them and giving them all the means of smoking cessation? At the time of lung cancer screening schedule, you can schedule it at that point of time, or at the visit when they come to your hospital for the low-dose CT scans, and after the participant has actually received their lung cancer screening results. Now, these are some of the encounters which are going to be fruitful in terms of smoking cessation. How to do it is a big question because we are all in the baby stages. We do not know at the moment how this program is going to kick up, but that doesn't mean that we are not going to focus on these kind of preventive measures along with our IP services. So focused attention is one form of the conventional way of doing it with the 5 A's and 5 R's, which we all know. I'm not going to focus on these things because we all know these things already. Group activities and community-based programs, which in studies has been proven to be better as compared to an individualistic approach, which should not be undertaken as a standalone procedure. So use of digital media is very, very helpful in addition to your community-based programs. Stepwise treatment is very, very important when it comes to your smoking cessation clinics, because we have seen that as we have a treatment plan for our asthma patients, we should be having a stepwise treatment which should conform to the severity of smoking in these kind of patients, wherein you are actually prescribing them controllers as well as relievers to take care of their cravings. Studies have shown that intensive and combination therapy is the best approach, and currently the smoking cessation uptake in India is about 12.5%. It was seen in a study in Kerala, about 12.5% of the population which came in for the smoking cessation was successful in quitting the smoking. Now, we are sitting here discussing about smoking cessation, but we all know that the effort should actually come from the government, and they should make policies to make this a health policy and integrate into the health system, including the Ayushman Bharat health program, which is giving free services to a large chunk of population in India. So 2022 amendment in cigarettes and other tobacco products, which is the COPTA Act, says that there should be removal of designated smoking places in hotels and restaurants. But when you see on the right-hand side of my slides, when I was at the airport, there are actually smoking rooms available at a public place, which is a high volume place like airport. So why should there be a sign of a smoking room when we are talking about smoking cessation? Prohibition of tobacco advertisements on social media and internet, but all of us know big actors are endorsing the advertisements related to Rajnigandha and every kind of cigarettes which we all see daily on the TV. Prohibition of production and distribution, which is the main problem here because it is a large industry. India is the second largest producer and third largest consumer of tobacco in the whole wide world. So is the government keen on getting down this industry when it involves so much of money? Increasing the sale of tobacco products to the age group of 21 years, is it being followed? No. In Northeast, it was seen that 69% of the current cigarette smokers and 78% of BD smokers could buy the BDs from a local store, pawn shop, and they were not asked about their age. As per the National Tobacco Control Program, the National Health Policy 2017 of Government and India has set the target of relative reduction in the prevalence of current tobacco use by 15% by 2020 and 30% by 2025. But how much of it is being achieved, we have to see. This is an image which should be followed strictly to be imprinted on the cigarette packets, which is being currently done. We all see that this image is there on the packet of a cigarette, and we have seen that when this GATS2 survey happened, the percentage of adults who thought of quitting because of warnings on the tobacco product was actually higher as compared to the 2009-2010 data. So yes, getting these images on the packets is seen being helpful. Now, what are the challenges and barriers to all these screening programs and smoking cessation programs? Designing, infrastructure, funds. Who's going to fund these? A lot of problems in India. Basic diagnosis is a problem. The training of healthcare is a problem. How much of you, as in a training program in VP Chest institutes, were asked to go to your smoking cessation clinics and get yourself trained in that particular program? I'm sure every one of us has a story here. So training is absolutely important when it comes to designing these programs. Distribution and assigning roles. Who's going to bell the cat? Of course, in private, everybody would be keen to do these programs because it involves money. But what about the public sector? Who's going to bell the cat? Extra amount of work. Who's going to do it? Utilization of service is again a problem here in India. There is no screening. Advice to quit is given to only 40 to 50% of the population. And there is a problem in the referral. And you can see the figures as compared to the USA data. Now, arranging follow-ups, this has been talked about already. It is a huge problem. How you're going to store that data is also, again, a problem. The AI has to get in and integrated with these kind of programs for their success. Promoting research. We have to do research. Unless we do research, we are not going to get good data, and we are not going to be able to actually follow the future trends and include the data in our daily practices. So what we are advocating here is comprehensive lung health program where tobacco use should not only be related to cancer, however, it should be related to many other non-communicable diseases, which India is the #1 country at the present moment as far as prevalence is concerned. It includes your cardiovascular health also. So it should be called Tobacco Dependence Treatment Program. All should be enrolled, not only those who wish to quit. You give your treatment to every asthma patient. You don't ask them if you want to get treated. You actually treat them. So all of them should be included. Teenage should be focused because we have seen this is the most vulnerable age and decides the sustained use in adulthood. It should be included in school curricula also. The smoking health, the lung health, how it is important, how it is going to affect your lungs in future should be instilled in their minds when they are very young. Legislation is very, very important. I just showed you how there is a plethora of advertisement available everywhere which prompts you to smoking and prevents you from cessation. Integration into the existing programs is going to be hard at one end and easier on the other hand, preventing us to spend more money when we have already such kind of programs as National Cancer Control Program and Non-Communicable Disease Control Program. I feel the states with high incidence of both carcinoma and tobacco use need to be focused upon, which is the Northeast at present in India, and disparities and heterogeneity need to be brought down. Thank you for a patient hearing.